From the editors of Biological Psychiatry and the Society of Biological Psychiatry, this is Biological Psychiatry Live. And I'm Dr. Tamara Gore, the social media editor, and I have with me today Dr. Garza Villereal. Could you please introduce yourself?
Yes, thank you. Well, my name is Eduardo Garza. I work at the Institute of Neurobiology in Mexico, in Querétaro, Mexico, which is a small city just near Mexico City, and at the UNAM University. And I did my MD in Mexico, then I did my PhD in Denmark at the Aarhus University, and then postdoc there as well, and then came back to work here.
Thank you so much for taking time to speak with me today about your publication in our journal.
No, thank you.
If you could start by letting me know, what is the current standard of treatment for cocaine use disorder, and what are some of the limitations?
So in general, there is no FDA approved treatment for cocaine use. And I mean, in Mexico, we don't follow the FDA that much, what we do. And even here, there is no standard treatment. So I guess the question depends on where you're standing. And that's one of the main problems, right? We don't have a standard treatment. We usually, people go to like treatment with the psychiatrist. Sometimes they go with the neurologist. Sometimes they don't even go to those places. They go to other places that have meetings and like group meetings, etc. So the first, I think, line of treatment is just self-help or help with other people that have the same problem, religious groups as well. And then once you get to the psychiatrist or psychologist, then the usual treatment, and I think that's also common in the US, is psychosocial treatment in other parts of the world as well, which is basically treatment with a group counseling or individual counseling. We also have that here, where people come and have counseling by a psychologist, psychiatrist, and they also have sometimes family therapy, which also works. Well, a lot of times we find that the family is it's a big it could be a big problem or a big help to the patient. And usually it's in the what you call the outpatient therapy. It's usually not within a hospital. And there's also other techniques that they use, like in psychology, they use cognitive behavioral therapy to prevent relapse, which is mostly what it's used for. And there are other ones I've heard about, like contingency management, that they happen to use sometimes in other places, which is basically giving them like either money or something that like a price for being with abstinence for a long time. And then you have the pharmacological treatment, like dopamine agonists. You have GABAergic agonists, glutamate antagonists, cholinergic agonists. You have a lot of medications that we still don't know which one works best, really. And every country uses different ones if they actually use them. And the main limitation is, of course, that precisely the success rate is not very high. Dropouts from therapy, it's really high, especially in cocaine addiction, for example. We found that, at least in our study, we had a really high rate of dropouts. And the longer time they're in the treatment, even if they're getting better, sometimes things happen in their lives and they just go. And even with the pharmacological treatment, even with that, the dropouts are really high. So the relapse goes from, I've heard, from 60% to 90%. So that's really high. And then relapse is also really high. So they live all their lives with this problem, and no one can do anything about it, really. I mean, it's really hard to treat. I would say they're very hard to treat.
Now, you've made it very clear just how many limitations there are and why your study was so needed to try to take another approach to treatment of cocaine use disorders.
Yeah, we need more. We have better treatments, and I think that TMS might be maybe not the answer, but another one that maybe we can use for specific things.
Tell me a little bit more about what understandings about the neuroanatomy or the neurocircuitry or the mechanisms underlying cocaine use disorder could be gained from the findings in your study.
Well, I mean, in general, I think so. One of the main hypotheses it's out there that about what TMS is doing to the brain in terms of why do people get better with TMS when they have an addiction, for example, or a substance use disorder. And one of the hypotheses was that an imbalance between circuits, like the circuit from the dorsolateral prefrontal cortex to basal ganglia to ventromedial prefrontal cortex, and that you kind of restore that balance in connectivity. That's one of the main hypotheses. And what we found was that it might be true in a sense, but I think there's a bigger picture we're not looking at. And one of my, I guess, a surprising finding for me, and I guess maybe not that surprising to other people, but to me was surprising that we found very little changes in connectivity within the dorsolateral prefrontal cortex and the ventromedial prefrontal cortex in terms of treatment success or reduction of craving and impulsivity in our case. But then the effect from the connectivity between the ventromedial prefrontal cortex and the right angular gyrus, but it was mainly both. So that has more to do with the default mode and that work. It was actually quite high. So it was quite predictive of treatment success in that sense. So at least in reduction of craving and impulsivity, because we didn't find any reduction on frequency of use, for example, which was a bit surprising, but could be, very different things going on. But in that sense, I think, and looking back at all the studies, there's a lot within the function of the default mode network that we're in addictions that we're not looking at, and I think it's important to look at, because it might be that there's something in the default mode network or in the resting state that tells us if a treatment is working or not in a patient.
That I'd like you to follow up on that last piece. So how do you envision this might play a role in clinical treatment of cocaine use disorder? What the information that you gleaned there, especially that last part, how
I mean,
clinically be implemented?
Sure. I mean, everyone is trying to get a biomarker, right? Especially with neuroimaging. That's one of the things. Yeah, that's when
something.
You strike gold if you get that, right?
Oh,
and I know for a fact that NIDA and the NIH are looking for like a biomarker with connectivity, and so one of the markers of that people are using now, and we're trying to use is Q reactivity, which is basically fMRI, task fMRI with a task that shows the drug and see how the brain responds to it and the craving that people get, and that seems to be predicting success on a treatment. But in terms of connectivity, I think maybe if we can find like precisely that biomarker, like default mode network connectivity, if it's predicting some kind of treatment improvement, that will be great. But I don't know if it's is the case that the DMN will be the one. I think a lot of work needs to be done first, and I think we need to go back before actually using it for TMS. We can use it for just regular treatment and how people get better, and if that's kind of a predictor of if a drug is going to work, etc. I think that could be used, especially because you can also use connectivity in animals. So if you do, like we do right now, preclinical models, and you can predict which one is going to get better from a treatment in animal models, then it's easier to just go and do other types of testing and to see actually what's the mechanism behind it.
Finally, what next steps are you most excited about in this line of work?
So as I said, right now we're working on trying to figure out the mechanism of how TMS works, RTMS, and other types of neuromodulation techniques. And so we're doing preclinical work with the animal models and looking at, right now it's DBS that we're looking at just as a surrogate for TMS, because TMS in small animals like rats is quite hard. So we're looking at that at the moment, but that's going to feed our human work. And I think the future for this will be, and I'm interested in the mechanisms, and by knowing the mechanisms, I think we will know how to make this therapy better, either for as a rescue type of therapy, or as an actual part of the treatment. And it's pretty benign, the TMS, and I think it will be a good good help, such as it's been used for depression. And right now, I think it was last year that the FDA approved TMS for nicotine use disorder. So I hope it gets picked up by other types of addictions, right?
Yeah, no, and it sounds like you definitely are laying the groundwork with this publication. So congratulations,
Thank
and
you.
thank you again so much for taking time to speak with me today.
Thank you. Thanks for having me.